This is the In Focus podcast from The Hindu.
Hello and welcome to another edition of the In Focus podcast. I'm your host G. Sampath. The Insurance Regulatory and Development Authority of India, IRDAI, has asked health insurance companies to offer their products to everyone regardless of their age, as per a new notification that is effective from April 1st. Until now, health insurance was readily available for anyone up to the age of 65, with companies under no obligation to cover those older. But this has now changed, and IRDAI has also asked insurance firms to extend their health coverage to everyone regardless of their pre-existing medical conditions. Now, both these changes are part of a wider set of reforms under the long-term goal of quote-unquote insurance for all by 2047, and they are mostly being welcomed as a positive development. But there is always the fine print, and questions remain about how these measures will pan out in real life. Health coverage does tend to get more expensive with age. Will the senior citizens, who are many of mostly dependent on pensions and are not earning as much as they used to earn during their professional lives, will they be able to afford the packages designed by private insurers? What do the norms say regarding the waiting period for pre-existing conditions? And will these measures be enough to reduce the out-of-pocket medical expenditure, which is one of the highest in the world in India right now? We discuss all these questions in this episode of In Focus, and we have with us Professor T. Sundaraman, a public health expert who has served as Executive Director of National Health Systems Resource Center and as Dean and Professor at the School of Health System Studies at the Tata Institute of Social Sciences, Mumbai. Thank you so much, Mr. Sundaraman. Great to have you back.
Thank you. I think there is a number of misconceptions about this announcement, and we need to be clear about the scope of this announcement. Firstly, the IRDAI, the Insurance Regulatory Authority, regulates the Indian health insurance industry, which excludes PMJAY, the Central Government Health Service Insurance, and the ESIC. So the actual number of people who are covered by the insurance that IRDAI regulates is largely private voluntary insurance, which is a very small amount of about 5 crore population out of an estimated 144 crore population. You also have group insurance covering another 19 crore, which together will mean about 24 crores, but which means in terms of families, that will be a maximum of about 6 crore families out of a much larger pool.
This includes the group insurance provided by companies, etc., right?
Yes, it includes the 19 crores is the individuals under group insurance of companies. 5 crores is the individual voluntary insurance. And there is another which comes, but is paid for by PMJAY, which is not really within this ambit. So we are talking of these two pools, 19 and 5 crores. And of that individuals, the number of families and number of people actually insured are less. It covers only a small part, not only of the population, but of those who are, or even among us, of people insured, a very small population is covered by this, right? We must note that in populations like ESIC, the coverage is much more, especially if you extend it. CGHS, it does cover elderly rather completely. So this is a problem that is exclusively in the private voluntary insurance side. Second, the earlier also elderly could be covered. But earlier there was a clause saying that it must cover at least till 65, so that insurance companies, which private insurance has the inherent problem of trying to maximize returns by having what is called adverse risk selection. I mean, you insure, try to bring more and more into the pool those people who need insurance less and less. So the less likely they are to be hospitalized or require health insurance, the more attractive they are as part of the insurance pool. Now, this is something inherent in this. To prevent, therefore, all them choosing only live, healthy population, this was clause was there at least till 65, meaning that you could allow insurance above that even earlier. But now that indicator line has been removed, which means there is a certain encouragement to go above the age of 65 also. However, and this I insist, there is absolutely no compulsion, no mandatoriness, no direction, no requirement for doing so. And in fact, what is going to happen is, and the insurance industry in its entire discussion around this seems to be encouraging it, is to make separate products for those who are elderly. Insurance products are called special different schemes, and they have multiple schemes with different premium rates for different groups with different adverse selection. And therefore, a separate insurance for them would be very costly. And at some point, therefore, even today, most people are not insured, not because of the absolute unavailability of insurance, but because the costs are prohibitive and the benefits are very limited. A third reason why this is so is insurance as a business, as a private opportunity, for entrepreneurial opportunity, works best if the risk is low, the cost, if the risk is incurred, is high, and the risk pool is large. So you must insure a lot of healthy people, of which a few may unfortunately acquire a few diseases which have high cost. But the elderly pattern is very different. So in elderly, the risk of disease is very high. Baseline disease and pre-existing illness, which is another major change, is almost universal, meaning hypertension or diabetes or arthritis or mental illness or neurological weakness becomes an increasing part of the population, so that somebody without a pre-existing illness is a rarity. And in some sense, you would have some people saying, look, I'm perfectly all right. They are equally liable. In many ways, they are also liable. But having said that, you are not, insurance is against risk. But here you have, they already have the disease and they are going to have disease. So as a mechanism, insurance is not a way. What you really are requiring is for being able to look at it over a lifespan and then cover the part when everybody will get old. If you just take the elderly and try to make a product for them, such a product is never going to be viable for either the company or the individual. In some sense, it is something that is inherently given to failure. In very advanced countries, where you have universal healthcare that covers everything, even in places like UK and the Japanese, you have a second insurance being taken for the elderly to allow certain qualities of care if you require. But for the basic care provision, you can't actually do it within the framework of an insurance because everybody is in need of health care and more people will need intensive health care and no actuarial calculation is actually going to break even on that. So in some sense, this remover of the pool is an indication of something that was already there existing. So I wouldn't read too much into it. Similarly, pre-existing illness, meaning suppose you insure a person with hypertension and cardiovascular disease, then before for 4 years they cannot get, if they get hospitalized for a cardiovascular disease, they cannot get reimbursed from insurance, right? Now they have reduced it to 3 years. Big deal. It's not really going to make much of a difference at all. And it is very, very poor coverage that it will provide. And if anybody is going to get insured for the first time above the age of 65, it's not really going to be very useful to do them. Above a certain age group, life expectancy itself is 7 years, 8 years. What does it really mean to do? You have provided them insurance. So I don't think that insurance, the product of a private market-based insurance, is ever going to be able to cover this. And I'm now talking only of this top 1% of the population which is into private insurance. I'm saying even for them, it's not a great deal. If you are talking of the other 99% of the population, especially a large part of the population who are not, could have taken insurance at an earlier age but have not, I don't see how it will work out for them at all. So we will need to rely on our three main insurance schemes, which is the PMJAY, the central government and the government employees health insurance schemes in the ESIC to expand insurance coverage than private voluntary insurance. Internationally, there are very, very few countries that have a basis built around private voluntary insurance. One of them is the US, but even there is an 8% government spend, 8% of the US GDP government spend on supply side initiatives, but then it is overall cost of healthcare is 19% of the US GDP, which is prohibitive, and Netherlands. There is no other country which has managed to do anywhere, and even they are in deep trouble on that.
Isn't Germany also based on an insurance-centric healthcare system?
Germany, the Japanese, these are sort of universal health insurance, mandatory insurance of the social insurance model. If you want to equate Germany with this, then you should look at saying ESIC being universalized is something like what Germany is. So the more you have organized, the more, if the majority of your workforce is in the organized industry, then you can have an employer contribution and an employee contribution and a state contribution that can balance for equity purpose. But essentially a payroll deduction that is done. That is the German and these universal models. It's like a universalized ESIC, not like the private voluntary insurance universe. There's a huge difference, you understand. Because then everybody is covered based upon their income, they have a deduction, but based upon their needs, they have a payout.
Does it mean those who are not employed are not insured? Those who don't have a job, they don't have this insurance in Germany?
So there are two things. One, those who have low paid jobs will have a lower payout, but to ensure that they have the same quality of care, there is a subsidy, cross subsidy transfer from the higher risk pools and the government payout. And second, when it comes to migrant workers and other domain, they are brought in the insurance cover by the state. So in some sense, you have actually somebody paying for them, or if it's an employer who is bringing in them with a work permit, then the employer has to pay for it. Eventually, they must find the person who will pay for it, so that in some sense, the employer contribution is paid. So it's a payroll taxation based system on the main with for the small groups, which are small, no, which are less than 5%. There will be different types of state cover and subsidy. But even there, the point is, because of the cross subsidy elements, the payout is, in terms of the claims, doesn't differ much. Okay, though hospitality may be better off, you may have a second insurance to have, let us say, a better quality hospital bed. But your basic care element, the cost of a bypass surgery, will be about the same wherever you are, whichever risk pool that you belong to. These are also called, at some point, the Canadian and Australian are single payer systems. So they pool the different risk pools. But when it comes to the payment, they are through a single rate fixed universally. The single payer system is a much greater universalized advance. This is what others are demanding for in the US.
What exactly is a single payer? Who is a single payer?
So single payer is usually a centralized agency under government control. What does it mean? Here, let us look at a situation in India. Who pays for healthcare? 60% of healthcare payment is out of pocket. That is, individual households pay for healthcare. Second, private companies pay for healthcare for employees. Government pays for healthcare for its employees. Then organized worker employers pay for healthcare. Then in some cases, government pays for healthcare for the poor. So you have 5 or 6 payers, right? In a single payer system, the payment to the provider is from a single agency, irrespective of how the payment from the person insured goes to that pool. So whether it is an employer paid or a government paid, they all pool that into a common balanced risk pool, an aggregated risk pool, and then from that pool, the agency reimburses all providers who are on an agreement. And all the salaries of the nurses, doctors also fall within that sort of their wages, for example, fall within a labor agreement. And therefore, the provider, everybody, I mean, whether they are rich or poor, whether they require whatever the level of service required, they pay the same. There may be some sort of co-payments of a small nature to prevent irrational care. So, for example, some countries will have, for the first visit, you will pay $50. Subsequent follow-up visits, you don't need. So, actually, if somebody is going without, just out of anxiety, then you may try to discourage him. But if it's a regular illness that requires subsequent care, then of course he is covered fully. So there are some payments, but these are largely token and to prevent irrational care use. But on the whole, the principle is that everybody is paid for from the same risk pool. How the insured person pays into the risk pool can differ. In some of the larger countries, this risk pool is completely tax-based because inherently tax is the most equitable system. The rich pay more taxes, presumably, than the poor. And therefore, in an equitable taxation regime, taxation is the best form of ensuring that payment is equitably collected.
Like which country has this? Which country has this tax-based mode of collection of payments?
Most of them, Canadians, the Australians, the Japanese, the Koreans, all of them have. Germany is payroll, but at some point, many of these countries have the Scandinavians, all of them have based on it. Some of them have additional payroll, but at some point, I think, in some of these countries, you can take an additional private insurance cover, for certain amenities. For example, the UK NHS does not cover dental work, certain areas of exclusion you can cover. But on the whole, the principle is that all of it is covered.
So what about the Scandinavian countries and the UK has this NHS? So is that the same, or is the universal access, universal healthcare different from an insurance-based universality of access?
There is some difference, but eventually on the ground the difference is not so much as one would imagine, because the experience of the person requiring healthcare and of the providing healthcare is very similar. Meaning what? Meaning that the payment is standardized to the provider, but the purchaser also has a similar experience irrespective of his ability to pay. Now in the UK, the general practitioners, primary care, is basically contracted in what are nominally private care providers. General practitioners are nominally private, but since they are contracted in, they operate on terms which are very government-like. It's not a salary, but it's a certain package, but which includes their salary on that. And all the major hospitals are under public ownership, the hospitals of NHS. So NHS is funded by taxation. And as we said, taxation is a equitable form of financing. And it's paid to people according to their different degrees of healthcare consumption. So it's a national health service, which is very similar to a single payer national health insurance.
Right. Now, coming to India, the Indian scenario, sir, you spoke about PMJ and CGHS and ESIC. So these three, which cover the majority of those who are covered in India, did they always have coverage for all age groups beyond 65 from the beginning? This IRDAI anyway does not apply to them. So old people were covered under this already.
Yes, but first remember the PMJY, CGHS and ESIC is still covering only about 30% of the population. We have never reached anywhere near covering of the total population in insurance scheme. For that, the public health services is the nearest substitute we have, because that's tax-based and government provided. The PMJY, CGHS, ESIC can empanel private providers also. So there is a difference in that. But having said that, these always did cover elderly. There are, however, certain clauses. So in CGHS, for example, at the time of retirement, you do make a lump sum payment. I think it's about 60,000 a few years back. I don't know what it is now, which covers you for the rest of your elderly. That is a one-time annual payment of 60,000 provides you a lifetime of cover above the age of 60. That's huge. Huh? Whereas over here, you would be having something like 15,000 per year, and the coverage in that is much higher. ESIC also has a scheme by which people on a pension or people who have been in employment under the ESIC for a certain period can extend their cover. These are very underutilized because of different operational inefficiencies. But essentially, the principle of covering into an elderly age are there. For example, the railways, which covers and say the Steel Authority of India, which are sort of in-house insurance schemes. They cover pensioners all the way. And in some sense, in the railways, the number of pensioners who are covered by the scheme can even outnumber the number of employees. Defense, for example. So the number of pensioners continues to grow. So, but both are viable. They are still the most affordable ways of covering the elderly rather than asking them to seek private voluntary insurance. So, I mean, in sum, this deletion of a limiting clause, which should not have been there in the first place, really brings about only a cosmetic change, which is in a good direction. It indicates a certain acceptance of a certain principle, a need. But beyond certain nominal acceptance of that need, in practical terms, it does nothing.
Right, sir. We spoke about how the cover of the private insurers is so limited. When we came to about 24 crores as a figure, and then there is the rest of the population which is covered by the three schemes under the government, and then there's a huge chunk which is not covered at all, and they rely on government health facilities. Now, in this context, the biggest challenge, the biggest problem facing the public health in a scenario here is the huge out-of-pocket expenditure, which is around 70% of the health expenditure in India, which is like really ridiculous. Now, is private insurance here, is it a part of the solution or is it a part of the problem? How do we address this challenge?
Insurance in any way not part of the solution. I was saying that insurance is only if the risk is low. But here we have universally, everyone requires health care. Beyond, as the age increases, the proportion of population in requirement of monthly health care. If you have a hypertension or a diabetic or an arthritis or a neurological disorder or a gastrointestinal disorder or a cancer patient or a renal patient, you are requiring in perpetuity health care. That is not an insurance-based cover. There, the architecture requires a universal access to primary health care, so that most of the care that the elderly need is available close to home in services which are of convenience, accessible, affordable, and acceptable to them. You must remember this, that if an elderly has to travel from, let us say, an interior district in Tamil Nadu to Chennai for health care, it's not going to happen. And for a regular monthly quota of, say, anti-diabetic drugs or anti-epilepsy drugs or anti-anginal drugs, can't travel far. It has to be convenient, accessible. So 80-85% of the volume of the medicines that they require have to be delivered close to home.
Right. I see your points, but the immediate counter which comes to this line of thinking is that it becomes unaffordable. Like the doctors and the specialists and surgeons and medicines and procedures are very, very expensive, and insurance is the only way to finance them. That is the argument which is put forth by various interests in the sector.
No, but that is only with a hospital-centric view. Most international understandings on this would say that the trick in this of cost reduction is to ensure that 70 to 80% of prior care is shifted to the primary level, and to enable it to be done with specialist consultation means that the specialist, suppose I do need, if let us say I have a cardiovascular disease, I do need a specialist consultation. But once the consultation is done, regular medication compliance, follow-up, the occasional breakthrough complication consultation, all of these must and can and must shift to the primary level. where the cost becomes much more affordable. Remember, the cost of essential drugs, even for the elderly, are cheap. They are generally affordable. It's only, and one needs to do something at that end also. I mean, one needs to do something at capping the cost of medication and diagnostics. Increasingly, the cost goes into unnecessary diagnostics. But if you take care of that, much of it can be, it is a question of reorganizing care. This current hospital centric or old age center specific institution based care model that can happen in the US is most inappropriate to us. It won't work. It won't work even for the rich.
Right. Hospital-centric approach to public health is not going to work in India. So one last question, sir, before we wrap up. Now, everybody,
And for elderly care, I'm saying the old age home, the special assisted home center, that may be required, but as supplemental to being able to offer elderly care at the primary level. It's just too costly to do it any other way.
right, primary healthcare is the big game changer in the Indian context, according to you. Now, one last question, getting the big picture here. Now, this entire discussion about making sure the elderly get ready access and affordable access to healthcare is happening in the context of India's changing demographics. As you know, when we have declining fertility rates, there is a life expectancy is increasing, and the proportion of population above 60 years of age is expected to triple from 103 million in 2011 to 319 million in 2050. So demographically, how much ground do we need to cover to ensure that, let's say, about 90% of people in India are covered by health insurance or an equivalent architecture that ensures that they have access to healthcare facilities?
There is a substantial requirement, and we have been talking about that. And my only contention is that as definitely healthcare needs will go up, and so will healthcare costs. Wherever whoever takes, and we talk of it as societal costs, meaning it could be borne by the individual household, it could be borne by the employer, it could be borne by the government. But eventually somebody has to bear that cost. You can do a lot with rationalization and efficiency, but still the cost will eventually go up. And you're right in saying that as the elderly increase, these costs are going to go up. I mean, there are calculations available of it, but that is again the insistence on how this care is organized so that they are delivered with the greatest degree of acceptance for the community and efficiency for the system. And that societal cost, again, we know is much better if we can have a much better dispersed network with good digital arrangements for continuity of care with the specialist and higher level. There will be hospitalization requirements, and those requirements will also triple. There is no doubt about that. I am not one who is saying who are pitting expenditure on hospital expansion against expenditure on primary care expansion. But even a triple-fold increase in hospital admission will not suffice if you don't get your primary care into place. If you have a good primary care in place, you can depressurize the hospitals, and with a much more rational, much more geographically balanced increase in hospital beds, one can manage it. It's a lot of supply side management also. Insurance is a financing mechanism. And if you are going to give affordable care, you're talking of being given care through public systems, not on a profit driven motive. And in some sense, you need to actually get your supply side right, whereas financing on the demand side is only a part of the problem. There is some relevance for the top 1 to 3, maybe even 5% of the population. But even there, as I was saying, insurance is not going to be the solution. We will need to look at health plans for elderly in the private market. It's an entirely different ballgame. Not likely to work even within our country.
Right, you used a term to describe the approach of private insurance. So adverse risk something. So what is the term you used? Adverse risk?
Adverse risk selection.
Selection.
Risk selection, the point is that you tend to take into the pool only people who are got low risk.
So the basic incentive is to not finance a particular health claim if you could get away with not financing it, right? I mean, we've all come across these kinds of situations.
The insurance insiders describe the business as working best if you give more and more insurance to people who need it less and less.
Yes, I mean, there's a fundamental contradiction here, as we know.
That's the best business model. If the motive of my industry is to maximize my profit, I must collect the maximum premium and have the least payout, right?
Yeah.
So it makes sense for me to encourage more and more people to enroll and keep out those people who are likely to need. So many people have actually got clauses that say that if you have had a high payouts in the previous years, then they tend not to renew your insurance on one ground or the other. Remember, private insurance is for a finite period, 1 year, 3 years. And if you are having a lot of healthcare needs, the chances that the insurance company will renew it becomes less and less. So it's an inbuilt business model. It's not something that some corrupt people are doing.
Right. So this business model, adverse risk selection, as you said, it's like right away. I mean, at first look, it goes against the very requirement, the very grain of the population profile above 65. I mean, people above 65 years of age should not be looking even to buy health insurance on this logic. So my question to you, sir, is there any kind of a solution here in this context where which goes with the government not increasing its expenditure on health from 1.3, 1.4% of the GDP? I mean, is anything at all possible without raising that expenditure above 1.5% of GDP?
Look, I'm not going to get into this issue of 1.5% of the GDP as a cap or as a requirement. For any level of expenditure, if we use a right care framework, you can get a better return. I do think that we can, within our current expenditure, do better, but there is going to be a need for higher expenditure. We aspire to be a developed country. So we aspire to be a country with a membership on the UN Security Council. All the other members have 8% of their GDP as public health expenditure. How are we so confident of being a civilized count among the most? We are saying we will have the third highest GDP. Should we even aspire for a third highest GDP if we are not willing to spend 5% of the GDP on the healthcare of its citizens? If we can't take of the elderly, what is the reason why we aspire for? Is it feasible? Is it desirable? So I think these are very fundamental questions. So I don't see this 1.5% as some sort of necessity. I really see that is being driven down by the need for private insurance and private healthcare industry to make more money in this crisis, rather than by the requirements of the economy as such. My sense is that actually bringing in elderly care into the current architecture of healthcare system, which is a combination of universal primary care by the public sector, a leading role of the public sector in hospital care with some supplementation using insurance synergistically in the secondary and tertiary sector, can take care of a lot of elderly care if it is organized very consciously into doing so. Today it has been excluded at the level of policy because we lived on a principle of selective minimal packages of care in the public sector and leaving the rest to the private sector. If we decide that we must do something on elderly care, it can be done. It's actually the political will to make the decision. In that sense, removing this line, which is actually an anti-elderly line, saying at least in 65 years, meaning after 65, okay, you can do what you want. That sort of signal having been withdrawn is welcome. But that's really something that shouldn't have been there on the first place. And now that it has been withdrawn, by itself will not solve the problem.
Right. Thank you so much, Mr. Sundaraman. It was a pleasure hearing you talk about this subject. Even this entire regulation from IRDAI is a cosmetic change, and private health insurance is not really the answer for elder care. Thank you so much for sharing your insights. Absolute pleasure talking to you. Thank you.
In Focus will be back soon with analysis of the biggest news issues. In the meantime, you can find our podcast on Spotify, Apple Podcasts, Stitcher, and other platforms. Just search for In Focus by The Hindu. We'll see you soon.